Hey everybody, it's I'm Graham, and it's my big disappointment that I'm not there with you. I mean, in addition to the pleasure of visiting Fiji again, it's been my heart's desire that we would start creating fire communities and um, interoperability focused communities in the Pacific Islands for all my Pacifica friends. And so I'm very disappointed not to be there. There's a certain amount of irony in the fact that I am now in Germany, where my wife is quite sick in hospital. I've just spent a day with her. And when she first fell sick, she got food poisoning, which turned into a full-blown metabolic crisis. Um, when she first got sick, the German doctors were desperate for her healthcare information. She was no way she could talk to them. She was way too sick for that. And so I was running around trying to find digital copies of medications, diagnoses, the last set of labs, the last colonoscopy, among other things that they said they needed. My daughters were highly amused that here was me, one of the digital experts, running around trying to find my wife's digital health information. And partly I'm super frustrating for me. It's going to make this easier. And here was I trapped like so many other people, millions and millions of people, in that cycle of information is we're in an information desert. So I'm really disappointed not to be there with you. Thanks, Baz, for inviting me to Better Systems, to inviting me to be there. I wish that I could. And now I have Fiji Airlines credit, so eventually I'll make it there, I guess. Anyway, let's turn to the presentation. So what do we do here? Open data standards transforming healthcare IT, because that's what we're about in the FHIR community. So a little bit about me first. I'm the FHIR product director at HL7, a past history of a lot of consulting around interoperability. I was the CTO for a laboratory and radiology systems vendor. Where I was there, I did business and product and tools development across the board. Before that, I did a PhD in clinical research. I was a bench scientist in a hospital lab. And I originally got my BSc in Auckland University, where I hung out with all the Pacifica kids, my best mates and friends. And before that, I was actually a farm kid in New Zealand with no idea where I'd end up. And I work through HL7. Now, HL7 is health level 7. It's obscure reference to an obsolete network model, but HL7 itself is not obscure or obsolete. It's the gorilla of healthcare standards. We publish lots of different healthcare standards. V2, which is pretty famous and loved or not throughout the healthcare industry, started in the 70s. Some other standards, and now FHIR is the new kid on the block. And I want to tell you about why FHIR and why I think that matters. Obviously, I do, because that's what I do for a living. And it's a choice that I made to push FHIR to the point where it was a reliable standard for the world to use. And I won't do too much tech, but why it's worth doing on top of the other standards which are more well established. And really, it came out of this analysis that I did back in 2011. And healthcare has broken processes. I'm living them right this week, but we all experience those. Everybody that I've ever met in healthcare is trying to run their little bit as at world standard, but the operative word there is their little bit. It's very, very difficult to get coordination across all the little bits. Other industries are being transformed. We've watched them be transformed to much more individually responsive business processes, much more flexible and more efficient economically. And that transformation was enabled by IT. My impression is that this is still happening pretty slowly in the Pacific Islands, at least last time I was there, not as rapidly as has happened in the more developed parts of the world. It's not necessarily a bad thing. But whether or not It's happening. To what degree it's happening is not happening in healthcare. It's starting to happen in healthcare, but it's really slow. And from my point of view, one of the reasons is that the IT standards to integrate business and consumers in business don't exist. They're not properly implemented. Now, I want to be clear. The real problems are elsewhere. They're not IT problems. They're culture, business process, liability, regulation. We all know what the problems are in healthcare. But for me, people could hide behind the bad IT and say, what's the point of trying to take those things on? And I sit in lots of meetings around the world where people are like, if only we could do this, we could, try and change our culture. And this turns out to be an enormous platform development in their IT systems that they can't do, they can't fund, they can't achieve if they could fund it. And so why would they bother trying to fix their culture when the IT systems lock them into their existing broken system, broken way of doing healthcare? And what's clear from traveling around the world and talking to people, both in first world and not so first world countries, the need to improve the healthcare delivery and outcomes is very great. And it's even greater in not so well off countries. I mean, I don't see how you can look at life as a potential patient and go, I'm happy with where we are. It's simply, it's not acceptable from my point of view, what we all get. And so I created FHIR. It's really the web for healthcare. And FHIR for me is two things: an open community and an open standard. And actually, the open community is more important. It's a community that's devoted to making it easier to exchange healthcare information. It's open participation. You do not need to do anything but spend your time. Okay, the most valuable thing you have, but your time doesn't need to cost. You don't need to register. You need to pay any participation fee. You just have to choose to spend your time. And we use open web infrastructure, social media. We're led by HL7, which means we're deeply connected to the worldwide health community. And then what happens is the community talks about how we could make it easier to exchange healthcare information. And we decide what's the least worst way to do it, which sort of meets the best set of compromises. And then we publish that as the open standard. And it's public domain, which I'll come back to, and it's web API, which I'll come back to. The other thing that's very true about it is it's got continuity with existing healthcare standards. I talked about V2 before. Sure, V2 is a syntax, and we totally abandon the syntax. But when you actually start looking at the data that flows backwards and forwards, you'll see real continuity in the way we think about data. And that turns out to be important, because if you didn't have that, people could invent cleaner models than they have, but any business proposition for an interop standard that starts with you toss all your existing records and forget them isn't something that happens anywhere in the world. Possibly, maybe some countries have a advantage, but basically no. We need to bring forward our existing healthcare system and evolutionary change rather than revolutionary change. So FHIR is a healthcare API. We basically made a list of the kind of operations that other programs could use that represent health functionality. And then they're often using web technologies that work remotely across the internet or locally, and that can be made secure. I'm not going to talk about security in this talk, but it can be secure. It does require discipline and culture, but the tech is there. And then FHIR offers healthcare services like, what's the patient details? Where is the patient? Can I get the lab reports for the patient? Can you prescribe a medication to the patient or dispense it? And can you suggest a treatment option for a patient based on the information that you have at hand? Those are the kind of services that we describe. And then they're basically building blocks that you build additional orchestrated, business operations on top of. One of the key things about FHIR for me from the beginning was that it's freely available. We make it available at hl7.org/FHIR. You just go there and see the latest version. The license is Creative Commons public domain. So there's no cost. There's no rights reserved by HL7. You can do whatever you want with it. We do protect the name FHIR in that you need written permission to use it, but I almost always give such written permission. But you can use, create, derive other things from it. Anyone can do anything. And for me, this is really important because in the other standards, they're all open now. They've all had to respond, and I'll come back to that. But it's key that they're open for two reasons. One is that if they're not open, then it's really hard to create open source libraries that represent the standard and make it easier to produce viable working systems that actually allow for economy of scale and for community driven development. You're just running into the fact that the license on the standards, the base thing that you're actually working with, says, no, you can't do that. It's a problem. And the other thing, and this is a bit obscure, but it was a real shock to me when I learned it, is open source is the worst thing you can get. When I heard that, I'm like, no way. And it was actually put to us at a conference by a well-known business speaker. And he said, you're all saying, which is exactly what I was saying, no way. But in fact, you ask yourself this question. If someone is giving something away, how can you sell something that's not as good? There's a few answers, but they're all transient and you're doomed. And so what he said is open source is always the worst thing you can get because you can't sell something worse. And so in a sense, open represents the floor of the market. And we just, as we ratchet up what we can achieve with open software, we ratchet up the pressure on the commercial systems. You can't sell product and then sit on your fat asses and charge for the fact that you're already there. You have to keep providing services. You can charge for services, you can charge for value, you can't charge for ownership. And for me, it's a key thing to push the software industry, which I had been part of, to be more responsive and to get more healthcare outcomes. And so we started publishing this idea of an open standard based on the web. And we built on it. A small, passionate community rapidly grew around the idea. And we built specs and tools and demonstrations and web presence. Some things went into production really very quickly indeed. Over time, the community matured and got big. Thousands of people are full-time on FHIR. I don't even have a way to count because you don't have to register. You can just do. Government stabilized and we were selected by Argonaut, which I'll come back to. And we just keep growing in meetings and social media and Twitter, which I can't even name anymore, and so forth. And we just keep growing because what we're doing is building public treasure that anybody can use. Here's a sense of kind of the hit rates on one of the open servers around the world. And you can see where people are using it from. I don't see any dots in the Pacific, which is, yeah, let's change that. The big blue dots, they're Amazon data centers. Yeah. They're not really representing a particular location. But very happily for me, you'll see the Melbourne dot is just a touch bigger than the Sydney dot. Now that is important. Sure, Kurt will agree with me. So we set out to transform three things. First of all, we set out to transform healthcare IT standards. We wanted to make them free and easy to access, and we have. It's now expected that healthcare IT standards will be free, and the few that aren't are under enormous pressure to make it so. It's not an easy transform to make, a transition, but it's possible, and they are under immense pressure to do so. And like I said, the license restrictions impacted most of all downstream from the standard. We've turned people to putting more weight on implementation success. Standards aren't something that is good for themselves, right? I don't work on FHIR, the standard, so I can wave around a published standard. I don't care. I work on FHIR so we can get better healthcare outcomes. And we built a whole bunch of things that everybody else has had to adopt and compete. And so everybody's better off because we have already transformed healthcare IT standards. So that was the first thing we set out to transform. And one of the things that was really changed, this is very different than it was 10 to 15 years ago. 10 to 15 years ago, HL7 maintained official collaborations with some of these organizations, but they were really not meaningful. And standards were each standard was a world to itself. And that we've changed by a great deal of energy and determination and producing outcomes and changing licenses and so forth. We now collaborate with thousands of vendors and providers, a worldwide thing. We collaborate with WHO, and I want to call out that WHO project that is coming, releasing smart guidelines for health, public health, to be a very significant driver of FHIR adoption over the next 10, 15 years around the world. We collaborate with SNOMED CT, with Odyssey for OMOP. If you don't know what that is, it's not, you know, if you need to know. Lots of national standards organization and health authorities, and we have communities and affiliates all over the world, BRICS countries. You can tell that I did this presentation last in a BRICS country and missed that on the slides. We would love to collaborate with Pacific Island nations, and I'll come back to that. Most countries in the world that are building healthcare architectures are now leveraging FHIR for our web and security and our tooling, and we're getting widespread adoption, and our job is to support that. It's not my job to actually evangelize FHIR. Well, here I am actually doing that, but it's not a paid thing for me. I'm paid by the US government to support US adoption. And anything else I do is like, yeah, whatever, but we don't get any money for that. You don't pay us for the standard. It's open and free. We give it in away to the entire world. And then people believe in that enough that they come to our meetings and they come and spend time with us. If you're wondering what the business model for that is, so are we. It's an ongoing struggle to make that work, like every other open source based business. I'm sure BS will be happy to talk to you about that or not. But transforming healthcare IT standards is in the bag. But let's talk about transforming healthcare IT. This is the kind of transformation that we want. And the fundamental thing that we achieved is reduce the cost of interoperability. From the beginning, I was clear about that. Interoperability is an economic problem. We can easily imagine this beautiful healthcare system that everything is freely available. It's not free. It costs a huge amount of money. And how do we reduce the cost of that? So let's take a case study. In 2010, it was what I called the year of personal health records at HIMSS, which is the big 50,000 person meeting of all of the super big business CIOs and health systems and vendors in the United States. And one year there was all these personal health record companies running around marketing their wares to the institution. So you can hook you up to our system. Our system will hook patients up. You can build a nice, strong brand recognition and lock in your patients through a personal health record that provides them with their health data directly. And I went around and I started asking people at HIMSS, how much is this costing? What's the total cost for lawyers' fees and marketing and maintenance and troubleshooting? And the ballpark figure is very loose, but it was 150,000 US. And that it would be cheaper in other countries, like in Australia, probably 60, 70 instead of 150, but that's kind of what it is. That's what it would have been for the company that I was working at as a total cost. And then the government instigated a project involving the big US EHR vendors. The vendors ran the project, but the government gave them the goal. Said, if you don't do it, we'll do it to you. So you do it. And the vendor said, okay, we'll do it. So the goal was to define a public API for patients to get their own data. Not a business goal, a government goal for the good of the population. Secondary goal, you could use the same API for application extensibility, which was a business goal. So there was a confluence there. And the outcome of a couple of years of work shared between the government and the vendors and a few key providers was an industry specification, which is now called US Core, for letting the patient get their own healthcare summary directly from the system. Medications, allergies, labs, all the standard things, and all done securely. This was great. And then Apple actually adopted this. This is, as far as Apple knows, the only case where Apple has adopted without dominating an external industry specification. So Apple HealthKit means that anybody with a phone in the States, the Apple phone, although Android have some equivalents, can just simply go to Apple Health, pick their healthcare provider off a list, and then get their healthcare data on their phone. Hospitals register with Apple for free. They get the software with the capability for free. They have to pass the Apple testing process, which usually doesn't cost them anything because the software is tested already. They do have to maintain patient portal accounts, which they would have had to do anyway. In some countries, they won't have to do that because that's done once by the government. But the reduction in costs is greater than 90%. That's what happens when you commoditize. So we reduced the cost of interoperability by 90%. When I said that at the start of this process, everyone laughed at me and said, there's no way. Well, I'm telling you, we did that. We didn't do that across the board. We've got to do that in other areas. But you get more outcomes for the same investment. And that'll actually increase investment as we get more outcomes. Again, change is not driven by IT. I'll come back to this. FHIR, IT enables people to solve the actual problems. So we're just building enablers. We do intend to be disruptive. I don't care about businesses. Big businesses, small businesses, if they provide a useful service, we should pay them. They should make some profit and pay their people. I don't care about that. What I want to do is disrupt clinical processes towards interoperability and shared content and better health outcomes, and I'll come back to that. But for me, the key way of changing your mind about how you think about this is that in the old way, on the left here, we would build a system which was an enclosed walled garden or an island, if you want to think of it that way, is probably more pertinent for this audience. And then we would specifically enable particular kinds of integrations on the perimeter of the system, and we would write them use case based one at a time, and we would charge money for them. That's how the model works. On the right is a new model where a company says, we're just going to build integration points into the core of the system. That's part of how we do our own work, is making our own internal framework open and free. And that leads you to a software product that is inherently more robust and stable. And the single biggest deal, actually, because this issue comes up again and again and again, wherever I am, we don't have enough people. And the reason that we can't get enough integration points in the left side model is we can't get enough people who can write the integration. But in the right-hand model, you use standards for the integration model as part of the system, and everybody knows how to use the system because everybody knows how to use the standard. Okay, not everybody, but a much larger group of people. Now, I love FHIR. FHIR, we work really, really hard. It's been 15 years since we started. No, 14 years since we started. But FHIR's not a silver bullet. See, it's a platform standard for which we can put in the rules what everybody agrees to. And the international standard can only standardize things that everybody will agree. Countries have different ways of doing healthcare, different priorities about healthcare, different ways of paying. Although I've never thought that how you pay for it makes that much difference. And from where I sit, the problems are the same everywhere in the world around coordination and collaboration and free information flow. It's always a problem. But people, they use different languages, they have different rules, they code medications differently, they allow different kinds of medications. Everything's different. And so we can't put in the base standard and tell countries how to do healthcare. And so the standard is nowhere near as detailed and agreed and comprehensive as people want. Parts of it are comprehensive, but most of it is, now you have to figure out how you're going to use it. I wish that we could get everybody to agree, and I have this kind of fantasy that one day we'll get everybody who does healthcare IT in the world, and we'll lock them up in the MCG in Melbourne, and we'll say, you can come out when you've agreed about everything. Yeah, it'll never happen. So people still need to actually make their own additional agreements. And the basic rule is the smaller the circle of people, the more you can agree on. The more you have in common, the more agreements you can make. And countries, domains, terminologies, kind of business agreements, those smaller groups make their own rules. So there's always work to be done. It's not just like it just happens. And so in order to deal with that, in order to make it work for your country, you'd build local community. That's one reason why we don't go around the world. We always accept invitation to speak. Here I am speaking, wishing I was really there. But we don't have a marketing strategy or an outreach budget that we run around the world trying to sell something. We're not selling something. We're telling you that we're here to help you build a local community so that you can make it fun, you can use it. Now, I'll come back to some challenges with that, but you need a vision, a strategy and architecture. You need an education process to build a workforce. You need learning and testing opportunities and local specs. So let's have a quick look at those. Community is critical. You can want change at the government or the provider or the healthcare level or the consumer level, political, but someone has to actually be able to do the change. If the capability doesn't exist, then it can't happen. And the community is workforce, capable vendors, informed purchasers, insightful regulators. Those are all priceless. Every single country that I go to says we need more workforce. Every company, every provider, everybody says we need more people, and we're all competing for the same number of people. So we need to build more. And one of the things that's really important is a vision to drive change. We want interoperability. It's not something that naturally happens. It's a kind of a broken market thing. The Pacific Island community may have different opportunities and challenges than others, because one of the challenges in the first world is there's so much investment already in place and so many existing agreements. And those are good, but they also hold you back. It's good to have them. And so how do you deal with them? Whereas countries that haven't built those systems, you really have to figure out what the cost of change is, because you just go ahead and implement. And actually, no, I'll come back to that. So, but the key is education. Every single country's biggest issue. One country I heard at a WHO event say that they had enough workforce. And I happened to be sitting next to one of their leaders, the tech leaders, and he turned to me and he said, what on earth did they say that for? We never have enough workers. Nobody ever does. And it's actually a harder problem for smaller countries, particularly because, and this is a real issue, say you decide to put in a real education effort to educate a workforce to do healthcare data management and healthcare interoperability, suddenly they're worth a lot more somewhere else than where you trained them. And companies have the same problem. And the only way that we can solve that is to build a big enough workforce. So tertiary education around digital health, record keeping standards, data exchange. There's also a role for post-workforce education. And I'm sure that you've heard this, but Australia and New Zealand are very happy. I know that I've heard this, very happy to work with you to spread our work there. Then there's need for learning and testing for people to actually test things, and students in particular to be able to do that. I'm not going to go through the details of this. But then you need local and regional specs. So that's all fine, but we're here in this country, we do some things. In Australia, we've got special coding systems, special rules around Indigenous health and tracking, closing the gap, tracking things, some very creatively unusual ways of thinking about how people interact from the Indigenous communities that drive some IT system behavior. And but then every country's got their own equivalent. One thing that's really interesting is regional specs. For instance, the Scandinavian countries have got together and said, we're not a big enough market to have our own rules, but we need our own rules. So we're going to collaborate together and have one set of Scandinavian rules. It's pretty obvious where that could go for the Pacific Islands. I do want to call out a couple of really key international specifications, in particular, the International Patient Summary. So the International Patient Summary is a particular way of using FHIR to represent a single package, a document that's agreed summary information about a patient. Common content, common terminology, portable, and the patient has their own. They're not dependent on anybody else. They carry it. They turn up at institution, show the institution their QR code, which they could have printed or they could have on their phone, and then the institution can access their record directly. And the specification doesn't specify how transfer happens. At the moment, what we have international agreement on is the content and the push for International Patient Summary. There's a partner implementation guide, which is International Patient Access, how you would actually get access to the patient summary information and the patient summary document itself. An IPS document has the subject, who the patient is, who wrote this, where the document is owned and lived, medication, allergies, problem list, immunizations, history, medical devices for countries where that's pretty widespread, list of diagnostic results, past history of illness and pregnancy, social history information. These are pretty standard content, but what's really unusual and precious about this is that it's a worldwide agreement. And this year in particular, we have a huge amount of convergence from many, many countries through WHO and G20 and the GDHP, which is another international country-to-country group of digital health policy development, that we're really focusing and converging on IPS. And actually HL7 New Zealand and HL7 Australia are holding a Connectathon in November with a focus around the practice connecting different systems, with a focus of handling the Pacifica seasonal workforce coming into Australia or New Zealand and bringing their medical history, medical details with them, and working out what does that look like technically, so that then we can go and say, what does that look like, at the jurisdiction, regulation, political level. NATO is just as interested in IPS for data interoperability between NATO countries. And really, it's a really simple idea. On the provider side, you create an IPS, a summary of the patient, and you transmit it to the consumer. Notice that these are not necessarily, like, consumer isn't the only way to store. So maybe the country will store when the consumer accesses, or maybe the consumer will store and then they choose to share and they give it back to the provider. And so we go around this circle. For me, it's really exciting. Not because it's particularly rocket science, it's a pretty straightforward idea, but it's exciting to see that we're really converging on actually doing it. Doing it is what we really need. So we are transforming healthcare IT, but all of this is pointless unless healthcare itself improves. And we're just starting to have an impact here. We got distributed and asynchronous follow-up clinics, which are now running entirely FHIR-based. These things were possible. They could run without FHIR, but they're easier and more feasible to get to. It's that economy of scale and the reduction of cost that makes this possible. Distributed marketplaces for service provision, like, for instance, in India, where if you think, I'm not sure if it's still running, but the system was, if you thought you might have COVID, you could make an online appointment for an immediate consultation. Someone in the world somewhere, someone in India somewhere would take your call, work you through the diagnostic tree. Are you likely to have COVID? That was all FHIR mediated. Easier and cheaper public health implementations. Those things are in production at scale already. And delivery of smarter, more relevant decision support. AI. It's like I couldn't get through a whole talk without mentioning AI, so I have. Tick the box, we move on. But for me, the problem is institutions keep patient records for institutional purposes, not for patient purposes. Patient outcomes are hard to measure and hard to improve, but they have patients themselves. We have little influence over the process or the outcomes. My goal and the FHIR project's goal is the ultimate goal is to improve patient outcomes through giving the patient control over their record, which I want to point out, we want to make data accessible to patients and make data from patients accessible to the system, allow the patient to control data sharing between parties, and working towards creating a single common patient record where the patient keeps records for the patient's own purposes. That's not to say institutions won't also continue to keep records, but they can't retain them as if it's not actually the patient's work. Actually, the same applies to providers. When individuals who are providing healthcare, doctors, nurses, whatever, move between the system, they lose access to their previous records. Why does that make any sense? Institutions keep data for institutional purposes. Let's change it to people keep their own data for their own purposes. But I do want to point out that what is empowering for most people is not healthcare data. Yeah, we're sick. We know we're sick. What to do? So is actually the ability to provide services to the patient directly, which is what, in the end, FHIR is all about. It's about giving the ability to extend services straight to the patient through their mobile phone or their local connectivities, however they connect. And for me, a lot of this is around coordinated care. I've got enough time. So here's an example. My mother-in-law, I can talk about my wife right now, who's going to go bang, bang, bang between different providers as a travel insurance company says what they want, and the local doctors are like, no, we'll do it our own way. But no, my mother-in-law, she went off to a GP, told the GP about a problem she had. He sent her off to a specialist. The specialist put her on a medication. She went back to the GP. The GP said, no, don't take that medication. That's a really bad idea. So she stopped taking it, went back to the specialist, and the specialist said, if you're not going to do what I said, why would you keep coming to me? Now, I assure you, my mother-in-law can't cope with this. It's a major disaster in my mother-in-law's life that the specialist and the GP didn't figure it out between themselves. Instead, they argued through the patient by proxy. Lots of people have this experience. It's a dreadful experience. And for some categories of patient, particularly mental health, it's the worst thing you can do. And yet it's how the system works. We can do better than this. FHIR enables services for a distributed care plan and for virtual clinical review so that you don't have to do that through the patient. The tech's there, the standards are there, the examples are there, but we just need to say we want to drive that into practice. We want to make it real. Sorry. So I set out to disrupt healthcare and healthcare IT and the standards process. And where we have transformed the standards process, we are transforming healthcare IT, and we have begun transforming healthcare to significantly reduce the cost of data exchange and therefore to significantly reduce the cost of coordination and of care provision. We wanted to make it easy and natural to use the web at the tech level. We wanted to encourage the development of open community. And I haven't talked enough about that. The development of an open community is a self-scaling community. That's why we don't fly in from overseas to build systems. We don't support that model. We exist to help build a local community that can seed itself. And from my point of view, these are public treasure that we all own, and we're all richer because we all own it. And if one of us owned it, a company, none of us would be richer. It's a very unusual thing. And I encourage all of you to spend some of your time every week contributing to civil society, which includes some kind of community that builds public treasure, whether it's FHIR or something else, that's fine. And should you wish to build a local FHIR community, we are here to help you get that going. and make it part of the worldwide community of communities. So please join us in making healthcare happen. Thanks for listening. Healthcare IT interoperability happen as well, I should have said. Thanks for listening. I hope this wasn't too long and difficult over a video. Like I said, really wish I could be there. Who knows when I'll get home to Australia? Things are not going very well here. But hopefully I will meet with you in some future forum. Thank you very much.